Hello, this is Dr. Debbie Morris as part of our medical physiology course. And today we're going to take the information in the previous lecture on the autonomic nervous system and apply it to some organ systems to get a sense of how the information that you're learning applies to actual clinical medicine. We have a number of objectives. We're going to talk not about all of the systems that are innervated by the autonomic nervous system, but about a few, including the autonomic inputs to the eye and some of its associated structures, the sympathetic and parasympathetic effects on the cardiovascular system, and then a little bit about the sympathetic and parasympathetic inputs to the bladder and how they affect bladder function. You remember that in most cases and in most organs that are innervated by the autonomic nervous system, there is both sympathetic and parasympathetic input, and they are working reciprocally to coordinate function. Often the effects are opposing. In very rare situations, they have the same effect. But most of what we're going to be talking about today are opposing effects and how those opposing effects coordinate to create the functions that we need in those systems. Let's talk first about something that you're all familiar with, the pupillary light reflex. When you shine a bright light into somebody's eye, their pupil constricts, right? Well, why? There's a reflex. The light strikes the retina, is detected, is processed. Signals from retinal ganglion cells travel not just to the occipital cortex, but also, among other places, to a group of cell bodies in the brainstem called the Edinger-Westphal nucleus. A nucleus is a collection of cells of related function. Would you imagine that the Edinger-Westphal nucleus in the brainstem is a sympathetic or a parasympathetic structure? If you remember that the divisions between sympathetic and parasympathetic are anatomic divisions, right? Then it has to be parasympathetic because sympathetic cell bodies do not reside in the brainstem. They reside in the thoracolumbar spinal cord. So this Edinger-Westphal nucleus sends signals back to the eye through the third cranial nerve to a muscle that is called a couple things. It's called the constrictor pupillae or the iris sphincter muscle. It is a circular muscle, and when it contracts, it constricts the pupil. The pupil becomes smaller. This response is called meiosis. I am not going to add this YouTube video that is linked here to my video, but I would like you to watch it as a link in the PowerPoint that you have in required resources. Similarly, when dim light is perceived, there is a response of pupillary dilation. So when the signal for that the room has been dimmed is perceived, received in the retina, and processed by the ganglion cells, a signal is sent to the hypothalamus. Also, when epinephrine is circulating from a reaction such as fear or excitement or sexual arousal, that epinephrine stimulates the hypothalamus, and a signal is sent through the spinal cord to preganglionic sympathetic cell bodies in the upper thoracic spinal cord, which sends axons to ganglia in the cervical area. You remember the sympathetic chain ganglia, even though the cell bodies are in the thoracic and lumbar spinal cords, there are ganglia extending up and down from there. So there are ganglia along the cervical spinal cord. Axons run from those ganglion cell bodies, so post-ganglionic axons, along the circulation along the carotid artery and the branching arterial circulation to the orbit, where they innervate the pupillodilator muscle in the iris. The pupillator dilator are radial muscle fibers, which when they constrict cause the pupil to dilate. Here's a diagram showing the constrictor muscle, which is circular muscles, and the dilator muscles, which are radial muscles. The constrictor muscles, circular muscles, are under parasympathetic influence and have muscarinic receptors and cause meiosis. The dilator muscles, our radial muscles, are under sympathetic control, cause mydriasis, and respond to alpha-1 sympathetic adrenergic receptors. This little diagram or cartoon simply illustrates those effects. So light or no light comes into the eye where it is perceived by the retina, processed by rods and cones, processed by ganglion cell bodies in the retina, sending signals in axons through the optic nerve that go to different places in the brain. Some of them go to the hypothalamus when there is dim light perceived, which then sends signals to the thoracic spinal cord, sympathetic preganglionic cell bodies, sending axons out to ganglionic cell bodies in the cervical chain, sending axons out to the pupillary dilating muscles, which are those radial muscles under sympathetic control with alpha-1 adrenergic receptors. Bright light, the signals were sent to the Edinger-Westphal nucleus after the optic nerve, and from there, that ganglion sends axons to something called the ciliary ganglion, which is a parasympathetic ganglion, therefore close to the organ that it is affecting, and in this case it's actually inside the eye, the ciliary ganglion, sending fibers then that cause pupillary constriction. Now, this word here, norepinephrine, is a mistake. And this is something I actually meant to change on the slide, but I didn't. It would be a little hard to change it on the slide. It releases acetylcholine, which interacts with muscarinic receptors, causing pupillary constriction or constriction of those circular muscles, resulting in meiosis. So not releasing norepinephrine, but releasing acetylcholine. In addition, there are a lot of other things that happen in the eyes under the influence of the autonomic nervous system. One of them is a very interesting reflex called accommodation. I don't know if you've ever noticed, but when somebody is looking far away and then suddenly looks at something near, their pupils change and something else happens. The lens rounds up or thickens. This is a response that helps us with near vision. By rounding up the pupil, it allows us to focus on things that are closer, and also by constricting the pupil, right? Because if the Edinger-Westphal nucleus is involved, and it's a parasympathetic response, it has to be pupillary constriction. Um, so the reflex that we call accommodation of the eye is under parasympathetic control. In addition, the eyelids are under the upper lids, or a specific muscle in the upper lids called the levator palpebrae superioris, is under constant tonic sympathetic influence. So there's always a little bit of sympathetic influence coming from the sympathetic arm of the autonomic nervous system, from the cervical chain ganglia, that keep those upper lids raised, and when that's interrupted, you get ptosis, or a drooping of the eyelid. This slide is something that we will do as an exercise in class. If you want to look up the drugs and kind of answer the questions before we get together, you may do that. This diagram on top, and sorry, I'm having trouble with my controller because of my dual screens, but it shows both the sympathetic effects from cell bodies in the upper thoracic spinal cord, extending axons to a cervical sympathetic chain ganglion, extending axons both along vessels to the pupillary dilator muscle, these radial muscle fibers, which when they contract open the pupil, and also to the upper eyelid to keep that muscle, the levator palpebrae superioris, contracted and eyelids wide open. In addition, there are signals coming from the Edinger-Westphal nucleus through parasympathetic pathways through the third cranial nerve to the ciliary ganglion in the eye, radiating to the pupillary constrictor muscle, the sphincter muscle, the circular muscle, resulting in pupillary constriction or meiosis. All right. Understanding the difference between mydriasis and meiosis is important. Understanding which one is under sympathetic and which one is under sympathetic, a parasympathetic effect is important. Understanding the pathways and the neurotransmitters involved is important. The lower part of this slide is about salivary glands, and I'm not going to talk about that a whole lot, except that when I mentioned earlier that in some rare cases, both sympathetic and parasympathetic effects work together, both parasympathetic and sympathetic input increases salivation. So the salivary glands are innervated by the sympathetic and parasympathetic systems, and stimulation results in increased salivation. I want to talk briefly about a case that illustrates one point, okay, or a couple of points. So we have a 55-year-old smoker who presents with a couple of complaints. He says that he has some pain in his right scapula, his right arm is a little weak, and that's why he's there. He's there for arm and shoulder pain and weakness. But when you look at him, you notice that his right eyelid is drooping and that he has a somewhat constricted right pupil compared to the left pupil. You ask him questions relating to his respiratory system. He might be wondering why you're asking those questions, but you'll figure it out in just a minute when I explain. But he has no cough or hemoptysis. He's not coughing up blood. He's not short of breath. But you do a good lung exam along with your neurological exam. And on exam, you notice that he has very limited or no breath sounds in his very upper lung fields. And he's dull to percussion there too, which suggests there's not air there. So you get a chest x-ray. And when you look at the chest x-ray, this is what you see. He has an opacity in his right upper lung, and that opacity is suggestive of something called a Pancoast tumor. It's a kind of lung cancer. That particular kind of tumor, because of where it is, can actually interfere with or interrupt transmission of signals along the sympathetic chain ganglia, particularly the upper thoracic and cervical sympathetic chain ganglia. And that would result in a loss of that tonic contraction of the levator palpebrae superioris muscle so that the eyelid droops, along with a loss of the signals that normally would be going to the pupillary dilators, those radial muscles, so they stay relaxed and the pupil appears constricted. The third part of this syndrome that we call Horner's syndrome, in addition to that ipsilateral meiosis, the ptosis, is anhidrosis, or a loss of sweating, because if you remember, I think I mentioned earlier, but maybe it'll be later, that sweating is under sympathetic control. There are a ton of potential causes, Pancoast tumor being just one of them. You could also have trauma that would cause a disruption of the sympathetic chain. But Pancoast tumor is an important one, and it typically doesn't present with respiratory symptoms, but rather with pain, often referred to the right shoulder, sometimes muscle weakness, and Horner's syndrome, this triad of symptoms. So maybe I didn't mention earlier, but I will mention now that while we talked about reciprocal innervation from both the sympathetic and parasympathetic systems in most organs, there are some exceptions. One of those exceptions is in sweating and piloerection. So the sweat glands and the little muscles in the hair follicles that make the hair stand up when you're scared or upset or cold, goosebumps, they are governed only by sympathetic input. So there is only sympathetic input. Now, just to make it a little more confusing, but something that you will learn about in dermatology, the sympathetic postganglionic neurotransmitter, which is normally norepinephrine, in this case, and this case only, sweating and piloerection, is actually acetylcholine. So it's sympathetic cells generating the signals. They are traveling with sympathetic axons through spinal nerves to the skin. But at the postganglionic effector terminal, the neurotransmitter that's released to the effector organ, which in this case is either the sweat glands or the erector pili muscle, is acetylcholine, not norepinephrine. Most vascular smooth muscle is also solely innervated by sympathetic axons, not by parasympathetic. There are some exceptions to that. But this is important when in that fight or flight response, when we talk about the importance of sort of opening through receptors, dilating vessels to bring more blood flow to the muscles, the skeletal muscles, and constricting them to bring less blood flow, for instance, to the gastrointestinal system. Those are sympathetic responses mediated by sympathetic receptors, different receptors, but sympathetic. We're going to move on and talk a little bit about the autonomic effects on the heart. And one of the most obvious is heart rate. So heart rate is determined by a collection of specialized cardiac myocytes, cardiac muscle cells, that are called the sinoatrial node. And this is the place where the normal heart rate is generated. It's the normal pacemaker of the heart. It's a little bundle of cells in the right atrium, not far from the vena cava. There are nerve fibers from both the sympathetic and parasympathetic systems. The parasympathetic fibers here are coming from along the vagus nerve. The sympathetic fibers are coming through other nerves, and they function reciprocally. So, if there is an increase in sympathetic activity releasing norepinephrine at the SA node, the heart rate goes up, and a decrease in sympathetic activity results in a decrease in heart rate. If there is an increase in parasympathetic activity at the sinoatrial node, releasing acetylcholine there, then the heart rate goes down. And if there's a decrease in parasympathetic activity, the heart rate goes up. And so the parasympathetic and sympathetic inputs are working synergistically. They're working together to change the heart rate in response to various stimuli. So when you exercise, the heart rate goes up because of an increased need for perfusion of skeletal muscle and brain and heart and lungs and everything. The goal always being to maintain perfusion to crucial tissues and to maintain cardiac output. As another example, if you have rapid blood loss, there is a big sympathetic outpouring. That sympathetic activation results in an increased heart rate, again, to try to maintain cardiac output because the blood pressure has gone down, and it's important to increase heart rate through the release of norepinephrine at the sinoatrial node, and also the release of epinephrine from the adrenal medulla systemically to maintain blood pressure and cardiac output. In class, we're going to talk a little bit in small groups about what some drugs do to heart rate and to smooth muscle based on what I told you earlier. I want to just talk very briefly about these concepts. Chronotropy as a concept refers to things that change heart rate in the heart. So things that increase or decrease heart rate, sympathetic or parasympathetic, affect chronotropy. Inotropy has to do with the contractility of the heart muscle, and again, inputs on the sympathetic and parasympathetic side, depending with beta 1 and beta 2 receptors on the sympathetic side and acetylcholine muscarinic 2 receptors on the parasympathetic side, affect cardiac myocytes differently. Now we're going to talk about the genitourinary system and specifically about the bladder. The bladder is an organ that's composed primarily of smooth muscle, and we call that muscle the detrusor muscle. There are two sets of muscular sphincters that hold urine in the bladder or release urine from the bladder. There is an internal sphincter that is non-voluntary smooth muscle, part of the detrusor muscle. There is an external or voluntary sphincter composed of skeletal muscle. There is both sympathetic and parasympathetic input. The sympathetic input comes from lumbar sympathetic cells in the lumbar spinal cord. The parasympathetic input comes from sacral parasympathetic cell bodies. The bladder slowly fills with urine. As it fills and stretches, there are mechanoreceptors that detect stretch in the muscle and send a signal to the brain stem, where parasympathetic cell bodies take over, sending messages in the parasympathetic system that cause contraction through to the sacral bodies, actually, are what end up sending the ultimate signals, but the message gets sent to the brainstem. And when the parasympathetic output begins, the detrusor muscle contracts and the internal sphincter relaxes. So that's opposite, but they're both under parasympathetic control. The voluntary sphincter remains under voluntary control until you go to the toilet and release the voluntary sphincter and pee. So there is this reflex causing contraction of the detrusor muscle and relaxation of the internal sphincter that tells you gotta go, and you gotta go now, and then you hold until you get to where you can release. So there are sympathetic influence allows the filling. Parasympathetic influence allows the emptying, and there are opposite but coordinated actions. This last assignment will be an individual assignment, and I will give you instructions on Canvas, and it will be submitted on Canvas. If you have questions, please email me, and we will discuss them when we